delighted to be here to talk about this because this study has been something that I have felt very involved with over the past couple of years. I'll start out telling you that the provincial government, the Ministry of Health, had approached me about how is dementia cared for in acute care hospitals in about 2010. And through 2011, we had some discussions, and finally we came up with some funding from the BC Mental Health Foundation for a study. And I was the chief architect of the study, but Dr. Janet McElhenney, former head of geriatric medicine here at UBC, and Marcia Carr, a very special nurse from the Fraser, were co-leaders for this project. It was actually published, and if you want to see the whole thing, it is at this particular website, on the government website, which is in your handout. I don't have any conflicts. There's no drug company money attached to any of this. My objectives. I want to, from the study, describe some experiences of caregivers of patients with dementia in emergency and acute care. I think that's very important at this conference because the voices are considered terribly important, and the caregivers, I think you will hear about, have a lot to say. I want to outline some healthcare professionals' ideas about improving care for patients with dementia in the emergency and acute care, and to summarize some suggestions for improved care in emergency and acute care, both from the literature, the caregivers, and the healthcare professionals' views. Now, I have to tell you, in doing the literature review, that it is quite clear, as far as I'm concerned, the best use of the emergency department for people with dementia is not to use the emergency department. Absolutely true. But it is also totally unrealistic to think that they will never be there. So if they are there, then we should give them good care. And I think that's what this study is all about. So we did a literature review. We had a lovely medical student, Sonia Deltou, who helped us, and that's within the study if people want to look at it. Most of our findings were totally consistent with the literature. There was one finding in the literature that I found rather interesting that I didn't see elsewhere, and that was that in the UK, they're starting to develop emergency department areas just for the elderly, separate from the regular part of Emerge, in an area which is quieter, less chaotic, with more elderly-friendly vehicles like signs and so on, to actually help people. And I think that's something perhaps we could learn from, so that when people actually do come in, we have a better environment for them. But much of the rest of the literature really was the same as what our BC people had told us. We did take a qualitative approach, not a quantitative approach, so this was focus groups. So the Alzheimer's Society was very helpful in getting us caregivers, and we had 12 caregivers, 6 from the Lower Mainland, 6 from the rest of the province, who were able to define problems that they had in dealing with their loved ones when they went into Emerge or acute care. And they were from all over the province. There were 2 specialized nurses groups, which Marcia Carr helped us arrange, and that was 17 nurses, largely from, I think almost all from Fraser and Vancouver Acute. And we wanted to ask them because they have extra training, they are the real experts in these areas, so we wanted to get their views on some of these issues. We then had 3 healthcare focus groups with people who worked in emergency from all disciplines. There were psychiatrists, family physicians, geriatricians, social workers, nurses, OTs, managers. We had about 25 people in those 3 focus groups. And finally, 3 focus groups with people who worked in the acute care. And that was about 30 people. Again, from all over the province, so all 5 health authorities were represented. In acute care units, obviously you've got a lot of time and a lot more time, let's put it that way, and a lot more cognitive assessments can be done, and they are. In the acute care units, it's becoming sort of common, I think, that behavioral assessments tools are used, and I think that's important. I see Maureen Shaw in the audience, and at VGH there is a behavioral assessment tool which is modified by Maureen, which I'll show you. But also the Cohen-Mansfield Agitation Inventory is used. How many know what that is? A few. A lot more of you are going to know what it is. If PCIS training is brought in for residential care, the Cohen-Mansfield Agitation Inventory is part of it. So I'm certainly suggesting as a geriatric psychiatry that we, in general, look at the Cohen-Mansfield, because if it's used in residential, it should probably be used in the community and in the hospital as well. This is Maureen's chart, which is very helpful in assessing behavior. It's one of the handouts. Again, for depression, there's good tools. I use the Geriatric Depression Scale 15 as a screen. The PHQ-9 can be used. There is a scale, Cornell scale for depression and dementia, which you have to speak to the caregivers about, and it's about a 20-minute scale. And for functional assessment, obviously you have to choose your tools. The functional assessment by Lawton and Brody, IEDLs, and the activities of daily living is very common. A kitchen assessment by the OTs may be very helpful, and there are other ones that are used less often. Executive functioning, there is a specific executive 25 test done, and there's neuropsych testing. I think myself that what's really important is to do a clinical interview and look at the judgment and the clinical spectrum of how are people making decisions. And that's probably the baseline best test for executive functioning, and then doing some of the other tests as well. I'm going to come back to the frailty scale because I think it's important and it had been mentioned previously. So what did people say were the barriers to care in Emerge? You know what they are. Lack of time, the inappropriate environment, communication problems, use of restraints, lack of mobilization, a negative attitude sometimes on the part of the staff, and it was mentioned that sometimes people go into Emerge because they think of the acute GI bleeds and the asthma and the trauma, and they're not thinking of dementia, chronic care kind of issues. So it's not exciting to them. Well, we could make it exciting, but there may be some negative attitudes. The lack of specialized staff in areas where you don't have these specialized nurses. Catheters being used inappropriately. The lack of general education of the staff. Advanced directives not done in the community. John Sloan made a lot of the importance of advanced directives, and I certainly believe that. I don't think it's as easy as he said it was to actually get people to do it. And I would suggest that that's the reason why most of my patients have not thought about a rep agreement and don't even want to talk about it. And then I try to get them to. So I don't know about your patients, but mine don't necessarily want to talk about it. And it's an important thing to do, to actually get them to do that, because we do really need to know what are the goals of care before they have a crisis and go into the emergency. What is it that person wanted? And especially if they're suffering from a dementia, that needed to be done a long time ago, clearly. And the wait time for beds in acute care is far too long, and we know that. And the longer they're in the emergency, the more debilitated they become. And as John Sloan has talked about, from a hospital perspective as a whole, if they're in Emerge and they get filled full of medications because of their behaviors and become immobile and incontinent, don't walk, then they are really on that long, slippery slope. So what about in the acute care? Well, the inconsistency or lack of continuity. I certainly work in a hospital, and I don't know in all hospitals across the province what it's like, but there are hospitalists who are great, and I love them, but they change all the time. And so there's a change in the doctors. And with the change in the doctors and the change in the nursing because of the schedules, my patients' caregivers tell me they're never quite sure who's in charge. And it's a real difficulty with them, and the patients find it difficult because there's constantly changing. The poor environments. I was just up in Vancouver General seeing one of my patients up in one of the other floors, not the stat unit, geriatric psychiatry unit, where I like to have them, but I looked at these and they're chaotic. The wards are chaotic. There's so much noise, there's so many things going on, there's so much in the hallways that my patient was trying to actually walk with his caregiver, but he couldn't walk because he was constantly being interrupted by a barrier. So that's a problem. A lack of training of the staff, inappropriate staffing, not enough staff to deal with it, inadequate communication, and gaps in the community. I'd love it if the community had all the care it needed, but does anybody here think they do? No. So yes, we need to work on it, and I absolutely believe we need to improve the primary care and the home care in the community, but that's going to take some time. Obviously, there's the medication problems, too many specialists, as Dr. Sloan talks about, but I don't think it's just too many specialists. I think it's whoever is in charge isn't actually looking at those medications and thinking, is this necessary? Care approaches which are inappropriate, like restraints, the absence of advanced care planning, and perhaps a lack of engagement in the work with some staff, and not all, because some staff are terribly engaged.